Thank you for taking the time to complete this quality improvement survey and learn from this frostbite injury best management guideline. References utilized to build this guideline were from the Wilderness and Environmental Medicine Journal, Wilderness Medical Society, and the Plastic Reconstructive Surgery Global Open Journal. Upon patient presentation, it is important to identify and treat systemic hypothermia, trauma, or any unstable comorbidities. Once these are either addressed or ruled out, immediately remove wet clothes and jewelry. Rewarm extremities in water bath with a 98.6 to 102.2 degrees Fahrenheit temperature mixed with 1 bottle of chlorhexidine until the skin is red and or purple, soft and pliable to touch. This will take roughly 15 to 60 minutes. Rapid rewarming by water bath has been found to result in better outcomes than slow rewarming. Please use a thermometer to maintain the temperature range mentioned. If a thermometer is unavailable, a safe water temperature can be determined by placing a caregiver's uninjured hand in the water for at least 30 seconds to confirm that the water temperature is tolerable and will not cause burn injury. Because the water may cool quickly after the rewarming process has started, the water should be continuously replaced and carefully warmed to the target temperature. The affected tissues should be allowed to air dry or be gently dried with a blotting technique to minimize further damage. Most injuries do not become infected, but adding an antiseptic solution such as chlorhexidine to the rewarming water has theoretical benefits of reducing skin bacterial load. Adding an antiseptic solution to the water while rewarming is unlikely to be harmful and might reduce the risk for cellulitis if severe edema is present in the affected extremity. Fluid resuscitation. Vascular stasis can result from frostbite injury. No studies have specifically examined the effect of hydration status on frostbite outcomes, but it is believed that appropriate hydration and avoidance of hypovolemia are important for frostbite recovery. Oral fluids may be given if the patient is alert, capable of purposeful swallowing, and not vomiting. If the patient is unable to safely have any oral intake, IV normal saline should be given to maintain normal urine output. IV fluid should be optimally warmed between 40 to 42 degrees Celsius before infusion and be infused in small 250 milliliter rapid boluses, as slow infusion will result in fluid cooling as it passes through the tubing. Multimodal analgesia, with emphasis on IV narcotics in the emergency department. NSAIDs, or nonsteroidal anti-inflammatory drugs, block the arachidonic acid pathway and decrease production of prostaglandins and thromboxanes. These mediators can lead to vasoconstriction, dermal ischemia, and further tissue damage. Please provide at least a 600 to 800 milligram ibuprofen tablet upon presentation. Grade injury after rewarming. Grades of frostbite injury are based on the extent of cyanosis after rewarming and bullae after rewarming. If no cyanosis and no bullae are identified after rewarming, this is a grade 1 injury. A grade 2 injury is if cyanosis or clear bullae are identified on the distal phalanx. A grade 3 injury identifies cyanosis and or hemorrhagic bullae on the proximal phalanx upon or after rewarming. And a grade 4 injury identifies cyanosis and or hemorrhagic bullae on the carpal or tarsal areas after rewarming. Consider a post-rewarming x-ray to evaluate for fracture and or foreign body if concurrent trauma. If a grade 1 injury is identified, consult the burn team. If safe for discharge from the emergency department, please send with a multimodal pain medication regimen to include an NSAID. Wound care instructions should instruct the patient to apply bacitracin, gauze, Kerlix, and tape. Bacitracin is used as a topical antimicrobial agent in the treatment of burn wounds, primarily to help prevent superficial wound infection. It assists in maintaining a moist wound environment that promotes re-epithelialization and reduces the risk of desiccation and secondary infection. Please ensure the patient has close interval follow-up with the burn clinic, and please consider providing tetanus vaccination prior to emergency department discharge. If a grade 2 to 4 injury is identified, the patient would benefit from admission. either to a hospitalist service or the burn team. Again, please provide multimodal analgesia to include an NSAID. Elevation of extremities is important for decreasing edema and promote healing. Consult our social work team. Again, please consider tetanus, and please place a consult to the burned wound nursing team. Again, instruction should be to apply bacitracin, gauze, Kerlix, and tape, to place Telfa in between the fingers and or toes, to drain clear and cloudy blisters with a needle, and to leave hemorrhagic blisters in place. Clear or cloudy blisters contain prostaglandins and thromboxanes that may damage underlying tissue. Hemorrhagic blisters are thought to signify deeper tissue damage extending into the dermal vascular plexus. Common practice is to drain clear blisters while leaving hemorrhagic blisters intact. Please ensure the patient has daily photos to identify wound demarcation if any infection is developing. And please evaluate again for developing infection, gangrene, and or compartment syndrome. Thank you again for taking the time to complete this survey, and hopefully your knowledge on the management of frostbite injury has expanded after this educational video.